have another session of case-based discussion on CA penis. With us, we have Dr. Anand Raja, who is professor of surgical oncology with a special interest in uro-oncology. And he's from an institute where one of the most landmark paper of CA penis have come, Adyar Cancer Institute. With us, we have two final year students, Dr. Manav, who is from KMC, Chennai, Kilpak Medical College, Chennai, and Dr. Amit Kavle, who is from Meenakshi Medical Mission, Madurai. Over to you, Manav, for the case presentation.
Okay, sir. Thank you, sir.
I'll stop my.
I'll start with chief complaints. 50-year-old male patient, a resident of Nellore, farmer by occupation, of low socioeconomic status, presented with complaint of growth over the penis since 6 months. History of presenting illness. Patient noticed a small painless nodule of around 5 mm over the PPU 6 months back, which gradually increased in size over last 6 months to current size. History of mild seropolidal discharge from growth present. No history of bleeding from growth. History of inability to retract the preputial skin completely is present. No history of phimosis or circumcision. History of multiple sexual partners present, now unable to perform sexual intercourse. No history of any urinary complaints. No history of perurethral castration or urological intervention or trauma. No history of weight loss, bone pain, jaundice, breathlessness, or chest pain. There is no history of diabetes mellitus, hypertension.
Okay, just wait. So just go back to the previous history. So history and present history. So what do you think he has?
Sir, as patient is 50-year-old farmer and having a history of multiple sexual partners and having a growth which is enlarged in last 6 months and a history of unable to retract the PPUs also. So I'll take this as it can be infective etiology, or it can infective etiology like syphilis, or it can be lymphogalanoma venereum, or it can be or it can be cancroid. Or secondly, I can take as pre-malignant conditions like HPV related or non-HPV related, or I can take carcinomatous changes like CA penis or any Kaposi sarcoma or any other subtypes of CA penis.
So you've given me a differential patient presents with multiple sexual partners with a history of inability to retract the prepuce, which is not amounting to. What's the difference between inability to retract the prepuce and phimosis? Are both of them the same, or are they different things? What is it that you're trying to do? Like,
sir, inability to retract the PPUs, it can be due to present changes like blepharospasticity, or can be growth due to growth which is not allowing.
Oh, but you said phimosis is absent. You said inability to retract the prepuce, and you said phimosis is absent. So are they contradictory? If you go back to your slides, you said inability to retract the prepuce, but you said no phimosis. So what does that mean?
It can
the other present, aren't they contradictory? Is what I'm trying to ask you.
It can be phimosis can be due it unable to retract.
No. Yes, I'm not asking you the reason why the patient is unable to retract the prepuce. I'm not asking you that. I'm saying inability to retract the prepuce, isn't that equivalent to phimosis?
Yes, sir. Yes, sir.
Yeah. Okay. So you've given me a diagnosis of, based on history alone, you said it could be either infective or cancerous, or you also said it could be precancerous.
Yes, sir.
So what precancerous lesion will present with a growth over the penis, which is
HPV related condyloma, giant condyloma can present as a growth.
But does the clinical appearance of a condyloma acuminata or a giant condyloma and the clinical appearance of a malignancy, aren't they very different?
Yes, sir. Yes, sir. As there is no bleeding from the growth.
That's okay. Bleeding may not be there in all growths.
Yes, sir.
So the clinical appearance, although we don't have
Yes, sir.
photographs here for other reasons,
Yes, sir.
but the clinical appearance of a giant condyloma acuminata or a giant condyloma will be very different from the clinical appearance of a
CA penis.
yeah
Yes, sir.
yeah. So that should rule it out. So you are left with either infective etiology or a or a
Or a
or a
cancerous,
or a, or a
malignancy.
or a malignant etiology. And you also said it could be Kaposi sarcoma. So so does the clinical appearance of a Kaposi sarcoma and the clinical appearance of a squamous cell carcinoma of the penis, is it the same or is it different? If
So
so,
is
how
it?
is it different?
So it is different, sir. Kaposi sarcoma appearance is not that not ulcerative, and and it can be present as uh,
In other
yes, sir.
lesions,
Yes, sir.
in other words, when you have a Kaposi sarcoma which will present,
Yes, sir.
will a Kaposi sarcoma have the same clinical appearance as that of a squamous cell carcinoma penis?
It
Ulceration
can.
will be more.
It is, what is its
Yes,
color?
sir.
It is usually not an ulcerated lesion like that of a penile cancer.
Okay,
It
sir.
can be purplish or reddish, or it is usually either macules or plaques or nodules on the skin which may ulcerate, and which has the characteristic appearances. If it ulcerate, it bleeds very easily.
Yes,
All
sir.
right.
Yes.
So that is the classical appearance. Although over a period of time, all those small nodules can coalesce together and then they can become very big, which can, I mean, the growth pattern can change very rapidly over a period of time. But that is the classical appearance. So does it appear to you like that?
Sir, it's not like that, but uh, with gradually over the time of 6 months, it can ulcerate. But I'll keep my diagnosis with the malignancy on the first. In the differential diagnosis, I'll keep my diagnosis of malignancy CA penis as the first diagnosis. Other, I will keep at the other
Yeah.
less priorities.
So once you say that the patient has got multiple sexual partners, so once you say multiple sexual partners, what are the things that will run through your mind?
So it can be due to low hygiene and due to HPV infection, which can lead to CA penis.
So multiple sexual partners, the first thing the things that should run through your mind is
Etiology.
whether he's a homosexual or whether he's a heterosexual. So did you ask that history? It's very, very important. Why?
As homosexual, the risk is increased, sir.
Yes, what else? If the patient, if the gentleman is a multiple sexual partners, if they are homosexual, so if you already have an established CA penis, you should also look for receptive intercourse, where you should also start examining the
Okay.
anal canal. Yeah, anogenital cancers are also very common in them. So you should always ask whether they are homosexual or heterosexual.
Heterosexual.
So
Yes.
if you think that he's got, I mean, just a word here, if you think he's got multiple sexual partners and then he's got a CA penis, um, compared to if he did not have multiple sexual partners and had CA penis, what would
Yes,
you
sir.
rather have? I mean, what would you think in terms of prognosis or outcomes? Which one do you think is better?
Sir, if the multiple sexual partner, the prognosis will be bad. It will be CA penis will be 3 to 5 times more. Relative risk is 3 to 5 times more in multiple sexual partner, and it
The
will
risk,
be subtype of this will be more bad prognosis will be there, sir. If it is HPV related or multiple sexual partner related.
I mean, again, I'm just asking you just so that you kind of get a broad overview
Yes, sir.
of the first things that will run into your mind the moment you get these patients. Amit, do you want to? I mean, do
So
you
it
think
will be
that
like if a patient is having a multiple sexual partner, it's like more related to HPV related, sir.
yeah?
Like HPV related CA will be more. So they will have like a poor prognosis for that.
So HPV related cancers, do they have prognosis that is better than conventional cancers, or do they have prognosis that is worse than
Worse,
non-HPV related
No, sir.
cancers?
worse, sir.
Are you very sure of that?
Sir, not sure, sir, not sure.
Yeah, usually HPV related cancers, the prognosis is slightly better as compared to non-HPV related cancers. So these are the things that should, these are initial impressions, the moment that run through your mind. So if you think that, so what do you think he is? Is he homosexual or heterosexual? Did you elicit that history?
Mm, most, sir.
No, you did not. So that's an important history to elicit. What else, if you think it's, what are the other etiological factors? One other important etiological factor that you should,
Smoking. Sir, I'll
yeah.
ask for smoking, smoking increase or tobacco chewing, or whether
History of any radiation, like a treatment for
psoriasis.
psoriasis, any has taken any treatment.
So did you elicit the history of smoking?
Yes, sir.
And you've written it down in your presentation.
Yes, sir.
Okay, good. So, okay, we'll come back to this HPV thing a little bit. We'll come back to this HPV a little bit later. Yeah, proceed. So do you usually you said no, just one more slide, please. Can you just go back?
Yes.
No, next slide. So you said no, what is PUC?
Sir, per urethral catheterization.
Catheterization. I'm so sorry, I'm very bad at these short forms. So how frequently in penile cancers do you need urinary interventions in terms of catheterization or not?
Sir, if there is lichen sclerosis or BXO changes are there, which can lead to CA penis, then there can be stricture urethra, which can lead to, we have to put the catheterization. We have to do the catheterization.
Okay, but otherwise, do you, if there are no BXO or lichen planus, do you ever need urethral catheterization in penile cancers?
Rarely, sir.
Rarely, sir, rarely.
Why?
Because urethral involvement is rare in CA.
One, because urethral involvement is late,
Rare.
not rare.
Late.
Urethral involvement is a late event in penile cancer. Suppose there is a tumor in the glans, then what? Will that cause urinary obstruction?
Possible, sir. Meatal stenosis, and that may cause.
Usually it never happens. Because even if the tumor will encroach onto the meatal, it will never cause a meatal stricture. What it will do is merely deform the meatus. The urine will find a different passage. It will never occlude it. The urine will usually find a different way to go on. So urethral or meatal involvement is extremely rare event in penile cancer until and unless you have BXO changes or lichen planus. Extremely rare. Why should you look for BXO? Again, there's a reason I'm asking this. So why should you look at BXO changes or lichen planus in a case with penile cancer? You should actively look for BXO or lichen planus in every patient with penile cancer. Why?
Because there is increased risk of CA penis, 2.5 to 5% increase.
So penis ho gaya. Abhi though there is already penile cancer is already there.
Yes.
There is no question of increased risk.
Yes,
now you already have a penile cancer. I am saying in every patient with penile cancer, you should actively look for BXO or lichen planus changes. Why?
Because we have to plan accordingly. If surgical intervention we are needed, where at which level it has involved the anterior urethra, penile urethra, we'll see, and accordingly we can.
That you will not give margins for the lichen planus. No, you will give like margins only for the
malignancy.
For the malignancy. You are not going to give margins for the lichen planus. So if the lichen planus or BXO is involving the penile shaft a little much more than what the cancer is giving, you are not going to go and give margins for that. Margins you're only give for malignancy. Amit, you want to try?
So BXO may sometimes involve perineal area also. So in case a patient is having high grade T3, T4 disease, and if patient require perineal ureterostomy, in that we have like perineal ureterostomy.
Yeah, the more maybe the simpler. There's a simpler answer to that. The simpler answer is that you should always expect that if the patient has got a BXO or a lichen planus, you are going to do a partial amputation, and after that you are going to catheterize the patient because you want to protect the the neomeatus, not the urethra, the neomeatus. You want to protect. You'll catheterize the patient for a few days. If the patient has got lichen planus or if he has got BXO, more often than not, you will have urethral strictures and all those things will be present. So after you perform the partial amputation, when you take the Foleys and you want to pass the Foleys inside, even the smallest Foleys will not go in. So at that time, you should be ready either for a urethral dilatation or you should consent the patient that, you might have a very small urethra through which he is passing urine. So you might need an additional procedure later on, or temporarily you might need an SPC in which the patient will pass urine, or he can pass urine via naturalis, but there's a slightly higher risk of infection or disruption of the neomeatus. You might not be able to pass the Foleys after the surgery. So these are the things that should run through your mind. That's why you should always look at
LS, lichen sclerosis and BXO.
BXO changes.
yes, it's a simpler explanation of it. Okay.
Okay, sir.
Yeah, next.
There is no history of diabetes mellitus, hypertension, or pulmonary tuberculosis. There is no history of any surgery in the past or significant drug history. No family history of malignancy. Consumed mixed diet. Bladder bowel habits are normal. Patient is chronic tobacco chewer since 15 to 20 years.
Okay, just one word and let's finish. What is the relative risk of tobacco and of smoking and penile cancer?
Sir, it is 3 to 5 times.
3 to 5 times, sir.
Okay, fine. Okay, next.
On general physical examination, general condition good. ECOG grade 1. Pulse rate 84 per minute. BP 116 by 84. Weight 65 kgs. Height 165 centimeter. No pallor ictus, clubbing, lymphadenopathy or edema absent. No pedal edema. Systemic examination normal.
Just one more thing here. Sorry, I'm just coming back to tobacco again. So when you say that tobacco and penile cancer, just to complete the subject here, does the type of tobacco, whether it is cigarette or snuff or chewable tobacco, does the type of tobacco impact risk of exposure?
No, sir.
Chewable tobacco will have more risk, sir. Like in lower socioeconomic is like one of the risk factor for CA.
No. We are not talking about we are talking about multivariate analysis. If you do multivariate analysis and if you do tobacco and tobacco products, does the type of tobacco impact the risk of malignancy? The risk is no. There have been studies which have shown that all forms of tobacco products, including cigarettes, chewable tobacco, snuff, all of them were significantly and independently related to the risk of subsequent penile cancer development of penile cancer. Yes, and the risk of one of the important thing is confounding variable. A lot of people who will have high risk behavior such as sexual history will also have history of smoking. That's one of the commonest confounding variable in penile cancer history. So does the association of smoking and penile cancer, is it independent of confounding factors or is it dependent on confounding factors such as sexual history? So the reason that I'm asking you is that if you go to the genesis of penile cancer in smoking, how does the molecular pathogenesis of penile cancer, how does smoking cause penile cancer?
Sir, it is due to increase in nitrosamine, which can
Nitrosamine? No. The cigarette smoking and penile cancer, the risk is that it inhibits the function of Langerhans cells, which are the antigen presenting cells. So because antigen presenting cells are inhibited, there is detrimental effect on the immune system surveillance. Because the immune system surveillance is inhibited, that's why the risk of penile cancer is increased. And where does the immune system surveillance come in? Because commonly in association with HPV, what happens is that there is a virus or a virion particle inside that is going to cause cytopathic changes. So that cytopathic changes, if the immune system is deficient, then the virus detection will not be done very efficiently, and smoking and HPV have synergistic effect which promotes malignant transformation. So that's why I asked you, does sexual behavior and smoking is smoking dependent on sexual history or is independent? So the answer is both of them are independent, but and significant risk factors for penile cancer. But when both are present, they act synergistically, having a multiplicative effect on the risk of subsequent malignant transformation. Am I clear on this?
Yes, sir.
Yeah. Come. Next.
There is no pedal edema, systemic examination normal.
Okay.
And then local examination, there is a 5 into 6 centimeter ulceroproliferative growth present on the distal penis, firm, non-tender, irregular borders, areas of necrosis present, does not bleed on touch, induration present approximately 1 centimeter proximal to margin, external urethral meatus visualized separately.
So
So
again,
picture
here,
is not shared, sir. Due to
that's okay. That's okay.
Yes,
That's fine. Amit, do you have to say something else about this in the local examination? What is it that he has not said? Is everything is everything present or is something deficient?
Sir, about the scrotum, how is the any
No, no, no,
pathology
no,
seen
no,
while
no,
patient?
no, 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 no. Before scrotum. So you have to quantify when you say distal penis. There is nothing called distal penis. So there are the parts of the penis that I know of are prepuce, glans, and shaft. So what is distal? I mean, you have to quantify. Is it involving the prepuce? Is it involving the glans? Is it involving the shaft or the distal shaft, or is it involving all the three? So that is what you have to say. Or you could alternatively also say, because you've said that you have difficulty in the patient has difficulty in retracting the prepuce, the entire lesion could not be visualized. So I'm sure you can only feel a growth. You can't see a growth on the penis. So is that what it is?
So growth is visible on the prepuce, and it is in glance is not visible properly, but
Because of phimosis.
because of yes, sir, because of phimosis, and distal penis, it is not involving the shaft, not involved much of the shaft.
What other thing you should tell me?
Sir, I have to tell whether in if chest penis, how much length from the base it's
No. You have to tell me whether the coronal sulcus is again involved or not. Why?
because management
Management will change, sir.
will change, sir.
What will be the management?
If up to coronal sulcus is involved, we can think of depending upon the histopathology. If it is a low grade, we can go for penile preservative surgery. Also, we can think about.
So what I was trying to ask you is, if the tumor is involving only the prepuce and the glans, and it is involving only the glans and the coronal sulcus is free, it's not coming up to the coronal sulcus. Circumferentially, the coronal sulcus is free. You can get away with doing only a glansectomy.
Transective.
Yes, sir.
So even a partial amputation is penile preserving surgery. All right, you preserved a part of the penis. So that's the important thing. What I'm trying to say is that the type of surgery will differ. So you have to say whether it's prepuce, if it's glans, is it proximal shaft, is the coronal sulcus involved or not. Here you should probably just say that I can visualize the prepuce, and through that I can see some growth, but I'm not able to see it fully because of phimosis. But yeah. And what is the other thing you should say? May not be in this case, but you should always say that remnant length, because you are going to plan. See, examination is not independent of management. So when you're looking at examination itself, the management should be crossing you should be thinking about it. So you should be telling yourself when you look at it, and you should document also saying that, and this is what I insist for all my residents. And I tell them that you see and you commit that the remnant shaft is suitable for partial amputation. It is not suitable for partial amputation. So you're already talking about management here. All right.
Yes, sir.
Yeah. Okay.
Examination of the inguinal region, 2 into 2 centimeter mobile lymph node palpable in right groin, no palpable inguinal lymphadenopathy in left inguinal region. Digital rectal examination, flat prostate, no significant enlargement.
Okay. Anything else? Okay. Anything else in examination?
No, sir.
Anything else he has missed, Amit?
Uh,
Whenever you have a palpable inguinal node, it is always better to say that no iliac nodes are also palpable on clinical examination. Or if the patient is very obese, you can say, the patient is obese, inguinal iliac in the right ear and the left iliac fossa, iliac nodes could not be evaluated, could not be ascertained. If he is thin, we can say that I palpated the iliac region and no nodes are palpable. You will be surprised at the number of nodes. If you have a small inguinal node, it does not mean that you will have a small iliac node. You can have small inguinal nodes with large iliac nodes. You can have large inguinal nodes with small iliac nodes. So, I mean, the two are not directly related to each other. Doesn't necessarily mean that you need a large inguinal node for a large iliac node. A large iliac node, if it's already there, will probably tell you that it's probably an entry disease.
And
It'll probably tell you what to stage, how to stage. Those things will already be going through your mind at that point in time. So always commit iliac region for iliac nodes you have examined, and whatever positive or negative findings or inability to examine, you always have to mention it there. Fine. So what next?
Sir, as patient is having 5 into 6 centimeter growth and 2 into 2 centimeter mobile lymph node, at this point, I can give the clinical TNM staging T1.
No. Amit,
Sir, I would like to do first some investigation, sir, basic lab investigation. Then,
yeah, tell me.
yeah, basic lab investigation I want to do, and after that, I will go for primary tumor biopsy. I would like to take.
Correct. Mana, always diagnosis, then staging, and then staging investigations. And then is finally when you stage the disease. It's a clinical staging. So you don't even have a histology and you're trying to stage. What if I tell you, okay, what have you staged it as? Go to the next slide. So you've already staged it about based on something. What if the biopsy comes out as say a sarcoma of the penis? Will you use the same staging?
No, sir.
So
First I'll do the wide local excision.
Wide excision. Wide excision.
Sir,
Mute.
diagnose it with
Biopsy comes out. You've done a wide local excision.
wedge excision, sir.
Wedge excision. No,
Yes.
wedge. It cannot. There is
Wedge
nothing
biopsy.
called as a. Yeah, it's a wedge biopsy. It's not a
Wedge
wedge
biopsy
excision.
will take.
There is nothing called as a wedge excision. Wedge can only be a biopsy. So Amit, what investigations?
Sir, I would like to do like complete hemogram, sir, HB, complete blood count, a renal function test, serum calcium.
Why calcium? You specifically mentioned calcium. That's why I'm asking. Otherwise, I wouldn't have asked.
If there is a hypercalcemia, it may indicate like extensive disease, like in of CA penis.
So does renal cancer have a paraneoplastic syndrome where there is excess calcium production?
Yeah, sir.
That will
How common is it?
So it's not much common, sir.
It's extremely rare. I've never come across. We treat quite a few penile cancers. I've yet to come across a paraneoplastic syndrome. Anyway, that's a different issue. So if you have to group investigations, how will you group the investigations?
Sir, I'll do the complete blood count. Then I'll do the coagulation profile of the patient, and then I'll do the serum electrolytes and renal function test of the patients.
Why electrolytes?
Sir, as I'm going to operate this patient, so I need the basic workup.
Electrolytes, is that part of your institute protocol?
Sir, we are doing regularly electrolytes.
Okay, so if it's part of your institute protocol, I have nothing to say. I mean, that's completely fine. But usually we don't do serum electrolytes for everyone. I mean, a routine hemogram, RFT, LFT, coagulation profile, and what else? One important other thing, diabetic profile, fasting
Yep.
postprandial. Chest X-ray.
Sir, if we are thinking in chest X-ray, we are doing regularly, sir.
Yeah, so we have to do for every case. So routine hemogram, RFT, LFT, coagulation profile,
Yes, sir.
and chest X-ray. So these will be the routine investigations that you do. So they are all normal, I hope.
Yes.
Yeah. What next?
So then after this, we can do the
Slide. So you've done a urine routine microscopy, a urine culture. I hope that's also he'll either have a
yes.
okay. WBCs are 8/9 high power field. What will you do next?
Sir, WBCs are 8 to 9. It can be due to some melanocystitis or some urinary infection, but other parameters are normal. No growth is there on culture. Sir.
Okay. Next.
Sir, ultrasound.
No. First, I told you again, it's always diagnosis. Only then you go to staging. Ultrasound was done of what?
Sir, ultrasound KUB and
KUB.
inguinal.
No. So without knowing it's a malignancy, again, we are coming back to the same point again. You don't even know what malignancy it is. You don't even know if it's a malignancy, and you are already going to stage the disease. Always diagnosis first, staging later on. Horse is first, the cart is behind. You cannot put the cart in front and the horse behind. Is that clear?
Yes.
Diagnosis first, staging later on. So what will you do to establish diagnosis here?
Sir, I would like to take the wedge biopsy from the lesion, sir.
Yes, sir.
Correct. Very good. That's the simplest thing. First is wedge biopsy or whatever wedge biopsy, punch biopsy, depending on site, characterization, and orientation of the tumor. You have to do a biopsy first. That will establish the diagnosis because staging investigations will depend on the diagnosis. Like I said, if it comes out as a sarcoma of the penis, you are not going to do the ultrasound of the groin, isn't it?
Yes.
Okay. So you've done a biopsy of the growth. What is the biopsy now? So you've done the so always remember you've done the metastatic workup without establishing the diagnosis. Never do that in the exam.
Yes.
Yeah, tell me.
There are features suggestive of invasive, moderately differentiated squamous cell carcinoma, and
Okay, so if you had to make up now the biopsy has come out as moderately differentiated squamous cell carcinoma. So how is squamous cell carcinoma graded? Is there a classification for squamous cell carcinoma of the penis?
Yes, sir.
Sir,
Two classification, sir. One is a WHO classification and another one is a match grading, sir. Match grading is according to the features like cytological atypia, mitotic activity, intercellular breaches. According to that, it is divided into grade 1, 2, 3 and sarcomatoid. And WHO grading, grade 1, 2, 3, 4. Grade 1 is well differentiated, grade 2 moderately differentiated, grade 3 poorly differentiated, and grade 4 undifferentiated, sir.
Have you heard of Broders classification? Broders grading system for penile
Yes,
cancers?
sir. Broader classification includes sir, features like cytological atypia, nuclear mitotic activity,
keratin
keratinization.
pulse.
Yeah, so can you tell? Yeah, so one of the commonest use is either the WHO classification or the Broders classification. The WHO classification is used more commonly for the purpose of staging. Why is it used more commonly? Because it gives you grade 1, grade 2, or grade 3. Because the staging will depend on the grading.
Grading.
What else is not there here? Anything else that you would ask a pathologist to tell you?
HPV status of the patient, and second is subtype of squamous cell carcinoma.
Okay, one is subtype of can you know about the HPV status? यहीं पे बोल के फंसते हैं कि
Sir,
अभी
what-
can you tell about the HPV status on gross pathology? Yeah, Amit, you are about to say something. Yeah, tell me.
Sir, some other points are also missing, like depth of invasion, lymphovascular invasion, perineural invasion.
Wonderful. So depth of infiltration should always be commented. Whether it's a well differentiated, what is the depth of invasion, you should always comment. If possible, on a biopsy, although this is more common with the excisional biopsy specimens, but if possible, extranodal, perineural invasion should also be commented upon in the biopsy specimen. Very good, Amit, very good. So surrogate markers for HPV in biopsies. If you have to say one word, what is it?
P16.
Yes, tell, correct, you are correct.
P16.
Who said that?
P16, sir.
Yeah, presence of P16.
P16.
There are two ways in which you can detect HPV in the biopsy specimens. Either you can go ahead and do a sequencing of the of HPV and detect the HPV DNA, or alternately you can look at the IHC marker, which is the P16. Now, how does P16 detection of P16 translate into detection of HPV? That is something I would request all of you to go and read up. It's beyond the scope of this class, but it's very makes a very fascinating reading. So please go and read up. HPV 16 is fine. मानो HPV अगर infection होता है तो what are high risk HPV and how does HPV infection occur? I mean, how does it transform? Just 3 or 4 lines. Which cells does it affect? How does it reach those cells? And how does malignant transformation happen? What is the natural history of HPV? Again, I'm asking you this in this patient because you repeatedly said 2-3 times that history of multiple sexual partners.
Sir, more carcinogen are HPV 16 and 18, sir, and these are mainly
Sir, that.
Yeah, but tell me.
Protein EP6 and EP7.
No. First, what are the HPV? What subtypes of HPV are related to malignancy?
Sir,
16 and 18.
18.
Any other two? These are the two most one. Anything else?
31, 32.
31, 32, 33.
31, 33, 16, 18, 31, 33. These are the most common predominant which are there in the community, which leads to penile cancer. How does it? Which cells does it affect? Which cells does it affect? All the cells, or which cells does it affect, and how does it go there? It usually affects the basal cells, the innermost layer of the epithelium, which is just above the basement membrane. That is where it affects. Those are the cells it goes. How does it reach there? Usko reach karne ke liye to they are the deeper most cells. No, there are multiple layers of cells above it. How does it go there inside? Because of micro trauma or micro aberrations on the skin during sexual intercourse, there may be micro trauma, micro aberrations where there is breach of the epithelium and the basal cells get exposed. And when an HPV infection is there, it will go into the basal cell and start infecting the basal cell layer. That's how it happens. Can you name 4 of those proteins that are usually associated with HPV? You said one P4, but before that, anything else?
Sir, EP6 and 7, I think.
There are 4 proteins: P1, P2, and E1 to E4. Okay, so these are the 4 more ones. So please have a look at. And what is the natural history? Does everybody who get HPV infection, does everyone get penile cancer, or is the virus naturally cleared off by immune surveillance? I mean, you can even hazard a guess. So the natural history is, tell me, Manish.
So 100% chance of CIC is there, but the carcinoma penis less
No. When you say about natural history, you have to have 3-4 numbers at your disposal, which you should be able to tell. First is what is the risk of persistent infection? Most of the infections, even with the high risk phenotypes, 16 and 18, almost all of them will be cleared off in an immune competent individual by immune surveillance. Second, what time frame will it be cleared? It is usually cleared off by between in up to 12 months, 12 to 14 months, almost all infections will be cleared. 1 or 2 episodes of HPV usually do not lead to persistent infections. It's very rare that a single infection will persist. It's more commonly repeated HPV infections will lead to persistence of infection. And then there's a whole gamut of changes where it induces changes, cytopathic changes, repeated infections, pre-malignant lesions, and then malignancy. Can you tell me what is the difference between pre-malignant lesions and in situ lesions of the penile cancer? Just to complete the discussion here. Are they the same or are they different?
Pre-malignant lesion, they are like benign course, sir, like which
Manav?
So pre-malignant conditions are the condition which can further lead to malignancy. But carcinoma in situ is that is below the basement membrane, and if it is
Below the basement membrane, or is it above the below the basement membrane? The invasive cancer is it?
is above the basement membrane, and it is not
So
invasive.
what is the difference? Can you name a few?
Sir, it can be Bowen's disease. It can be erythroplasia of Curette.
Correct. These are the CIs.
So
And
what is the difference? Correct. What is the difference between CIS and pre-malignant lesion? This is a very important distinction which you should know. Pre-malignant. Yeah, tell me. Tell.
The pre-malignant lesion, like clinically, they will appear as a red or velvety lesion, but
You leave clinically, man. You leave clinically. Histologically, what is the difference? Histologically, a pre-malignant lesion is a lesion, like for example, leukoplakia. Leukoplakia is a white patch that cannot be characterized as anything else. It has a higher risk of malignancy, but the pre-malignant lesion by itself has not induced any histological changes that are suggestive of malignancy. Do you understand? It's only a pre-malignant lesion. Like for example, in colorectal cancer, you may have polyps, colonic polyp. Colonic polyp may be a pre-malignant lesion, but it is not induced here. Leukoplakia. Leukoplakia is a pre-malignant lesion. It is not induced the histological or cytological changes that can progress to malignancy. Whereas in situ cancers, the histological changes which can lead to malignancy have already occurred. The only difference is that all the changes that have occurred, which are in either erythroplasia of Curette or in Bowen's disease, the cytological features or histological features have already occurred, but they are above the basement membrane. It is not progressed to below the basement membrane. Once it breaches the basement membrane, it becomes an invasive malignancy. Do you understand the distinction? Amit and Manav, are both of you clear?
Yes, sir.
Just to complete the discussion again here, what is the difference between erythroplasia of Curette and Bowen's disease? Just to complete the
Erythroplasia of Curette mainly involved the prepuce and the glans, and Bowen disease mainly involved the shaft of the penis.
Wonderful. So mucosal surfaces, the erythroplasia usually involves the mucosal surfaces, either the glans or the undersurface of the prepuce. All right, good. Can you tell me a few of the other histological variants of squamous cell carcinoma in the bladder of the penis? Sorry.
So it can be Vati, it can be papillary, it can be basaloid.
So just telling me the histological variants should not is not sufficient. So the moment you say a histological variant, it should have some connotation with clinical outcomes. So can you tell me something about the outcomes or clinical outcomes of these subtypes?
Yes, basaloid is poor is having poor prognosis, sir, and papillary having good prognosis, and there is Vati basaloid, they are having poor prognosis, sir, and Then verrucous also is having good prognosis.
So verrucous has good prognosis. What about warty?
Warty is also having good prognosis, sir.
prognosis, sir.
But what is the special? So these are some things that you should know in an exam. So what is the warty, are also called as condylomatous tumors, or so what is the typical thing in them? They are very slow growing malignancies where vascular or perineural invasion is extremely uncommon. All right, basaloid. Why is it high risk?
Because of invasion of
No, it's high risk because so. I mean, I'm so sorry. I don't mean to either tell you, but what you're telling me is based on very superficial reading. So if you have to say that basaloid are slightly more higher risk and this and that, the reason is because they are high grade tumors. Almost all basaloid tumors are high grade tumors. Because they are high grade tumors, they are at a higher risk of having inguinal node metastasis and outcomes and so on and so forth. What about sarcomatoid tumors?
so they are high grade.
Also high grade, sir.
High grades.
Yeah, they are one of the highest grade. They are the most aggressive variants of squamous cell carcinoma penis. So these are everything that you said. The conventional SCC, papillary, warty, basaloid, verrucous, and sarcomatoid. All of them are conventional RCCs. Can you tell me something about patterns of infiltration? So how the squamous cell carcinoma infiltrates local tissue, it really depends upon both the tumor as well as the host. It's called as the host tumor relationship. The pattern of infiltration can be either pushing borders or infiltrating borders. So pushing borders means that the tumor is very, very well defined. There is a sharp demarcation between where the tumor ends and where the normal tissue begins. Whereas in reticular, also called as infiltrative pattern of infiltration, there are blocks of cells that will infiltrate the normal stroma. So because of this, the nodal metastasis in reticular cell cancers, the risk of local recurrence, the risk of nodal or regional recurrence is much higher in infiltrative pattern in infiltrating tumors borders as compared to pushing borders of tumors. All right. Can you tell me some other cancers? These are squamous cell carcinomas. Can you have basal cell carcinoma that can arise in the penis?
Yes, sir. Basal cell carcinoma can arise, but it is very rare.
Rare, sir.
How do you differentiate basal cell carcinoma from squamous cell carcinomas on two ways? Histologically and on IHCs. Basal cell carcinomas are usually nodular. As it's the name, it usually arises from the basal layer of the epidermis. They can involve whatever structure, everything else, but they're usually nodular in appearance. And on IHC, it is usually negative for epithelial membrane antigen, EMA, which can aid in the diagnosis of squamous cell carcinomas are usually positive for EMA. Basal cell cancers are usually negative for IMA. Yeah. Can you have melanomas?
Yes, sir.
Yes, sir.
Melanoma can occur, but it is
Sun.
rare because it is not exposed to sun, more exposed to sun.
Can you have a Paget's disease?
Paget's
Yes, sir.
can be
Paget's
there.
also.
What is the site of occurrence of a Paget's disease? What is the type of cancer? Is it a squamous cell carcinoma? Is it a basal cell? Extra mammary Paget's disease. If you have to say one line,
sir.
what is the type of cancer?
Yeah.
It's an adenocarcinoma. And where does it arise from? It arises from the apocrine glands in the skin. So, last question on all these things. Can you have metastatic penile cancers?
Yes, sir.
Yes, sir. Possible, sir.
Yes.
So, penile metastasis, where? So, what
From
is the
bladder,
yeah,
bladder, prostate, or rectum?
yeah, you can have metastasis, penile metastasis. You can have from anywhere. The commonest is bladder, prostate, or
Bladder.
rectum, like you said. Anything else? One more urology organ you missed out. Kidney.
Yes.
Of all metastasis into the penis, you can have renal metastasis is about 10% of all cases. Bladder and prostate is about 30% each. Again, one last question on histology and penile cancer and everything else. Can you differentiate urethral cancer from penile cancer? Urethral cancers are also squamous cell carcinoma. Penis cancer is also squamous cell carcinoma. The prognosis, treatment, and outcomes are very different for urethral cancers, which is a squamous cell carcinoma, and penile cancer, which is a urethral carcinoma. How do you differentiate between the two? The only way to differentiate a urethral carcinoma from a penile carcinoma is location. If it's a urethral carcinoma, usually in late stages you can't find out how. I mean, if it's eroded through the urethra and onto the skin and everything is ulcerated, then you can't obviously differentiate. You just have to look at if the bulk of the disease is in the urethra, it's a urethral cancer. The bulk of the disease is in the skin, or the penis, it's a penile cancer. But very rarely, what you can find is you can have the tumor in the urethra can grow, circumferentially expanding where the skin is completely intact. If the penile skin is completely intact and you see that the tumor is predominantly in the urethra, that the anatomic location might be the only factor which helps you differentiate SCC from penile cancer. Fine. Now you have a histology of moderately differentiated squamous cell carcinoma. What next? So the point that I'm trying to emphasize here is histology and all those things are not just for cursory reading, for superficial reading. All those things you need to go into a great degree of detail, read up every single subtype, how to differentiate one from the other, because it is clinically relevant.
Yes.
Right. And it's not just for bookme that you read it up and then you write it on the answer, as a theory question. It's clinically relevant also. Okay, next.
Then now we came to know that it is a moderately differentiated squamous cell carcinoma, sir. And
Diagnosis you have.
yes, sir. It is it is T1 G2 and N. We are having only inguinal palpable inguinal lymph nodes.
How do you know it's T1?
We have to do further.
No, you already told me you know that it's T1. How do you know it is T1? What is T1 for glans tumor?
So subepithelial invasion into subepithelial connective tissue. T1A is without lymphovascular invasion. T1B with lymphovascular invasion.
So how will you come to know it is T1 or not?
So as per these histopaths, we can't comment on the T staging.
Exactly. All right. So
we have to.
Yes, tell me.
So we have to know the depth of the invasion and lymphovascular invasion. In this node.
For glands, T1 means lamina propria invasion. If it's lamina propria invasion, it is T1. Anything more than that will be T2. So you don't know whether it is T1 or not. You don't have a depth of invasion. So you don't know the T stage. Maybe you can say it's a clinical CT1. Probably if you say, I might agree with you. But you have to, it's preferable not to say that until you are very, very sure. Okay, CT1N.
And there is on palpation, there is single 2 into 2 centimeter node. And
how else did you stage the groin?
Sir, that is CN1 is single unilateral.
How, staging later on. First, you have to stage it. What did you do investigations to stage the groin?
So clinically, we can do.
And then you did something else, no? Jo aapne dikhaya, you showed it to me before also.
Sir, we can do CT.
Yeah, tell me.
We can do ultrasound.
Yeah. USG guided FNSC, we can to confirm whether it's a mace or a reactive lymph node.
It's a 2 centimeter node. Why do you want to do an ultrasound guided FNSC? Can't you just do a blind FNSC? He said a single node 2 into 2 centimeters is what he said. So for if it's a 2 into 2 centimeter node, you may be correct also, but I'm asking you why can't you do just a blind FNSC?
Yes, sir, we can do, sir.
We can do.
You can do. So you've done an FNSC of the groin. What about the opposite side?
So opposite side, it is non-palpable.
So if it's non-palpable, so what proportion of nodes will not be palpable by your fingers but are palpable on the ultrasound?
Sir, around 20 to 25%.
25%.
Say, tell correct.
Positivity. 25% positivity can be there.
Micrometastatic disease.
So around 30 to 40% of nodes which are not palpable on clinical examination, extra around 30% of nodes you can detect it on ultrasound screening of the groin. So you have done an FNAC of the ipsilateral groin, and then you have to stage the opposite groin also. How will you stage the opposite groin? The simplest way to stage the opposite groin is to do an ultrasound of the groin. And depending on the characteristics of the node, nodes are seen or not, round nodes, oval nodes, salty hilum present, absence, whatever it is, you have to do a guided FNAC. So a guided FNAC on the opposite side, an FNAC or a guided FNAC here, depending on logistics and whatever it is of the same side, that will tell you things about the groin. So what is the FNAC of the groin?
So, positive for malignant cells.
So did you do an FNAC of the opposite side and did you do an ultrasound of the opposite groin?
So ultrasound. Sir, on ultrasound, one of the lymph node on right side is heterogeneous, that is 1.9 into 8 mm, and there is small volume lymph nodes seen in bilateral superficial inguinal regions.
So probably what they're trying to say is non-significant nodes are seen on the
right,
left side.
Sir.
Left side. So is this staging enough, or do you want to further stage it?
As on right side lymph nodes are positive, then we can also go for pelvic lymph node staging. We can go for CT scan of the pelvis to know.
Is it only CT scan of the pelvis, or is it CT scan of the abdomen and pelvis, or is it because you have a positive node? Is it a CT scan of the chest and the abdomen and the pelvis? What is it?
CT chest also. Sir.
We can do all.
No, we can do a lot of things, but what will you do?
As a CT abdomen pelvis plus CT chest, sir.
Yeah, what is usually recommended is to do the NCCN guidelines always recommend that if you have a positive node in the inguinal region, a CT chest and a CT scan of the abdomen and pelvis should be done. Why should you do a CT scan of the abdomen and pelvis?
Sir,
to rule out the presence of any pelvic lymph nodes or any presence of any retroperitoneal lymph nodes, sir.
Yeah, correct. You can have, in the presence of inguinal nodes, you can always have, if you do only a CT scan of the pelvis, you will miss out on the retroperitoneal nodes. And you can also see, liver metastasis, although it's very uncommon, but high-grade tumors can have all of that. So you can see retroperitoneal nodes. So that's why you should always do a CT scan abdomen and pelvis. The data regarding CT chest, the NCCN recommends, I mean, you are not wrong if you say that you want to do a CT chest on top of a CT scan abdomen and pelvis in a groin positive node. But if there are no pelvic nodes and nothing else is there, if you have only, few inguinal nodes, the risk of having pulmonary metastasis is quite low. So in clinical practice, most people would just do a CT, will just do an X-ray, and based on the X-ray finding, ask for a CT chest. However, if you have multiple pelvic nodes and or retroperitoneal nodes, you could always do a CT chest.
Yes.
All right. So what is your clinical staging now? You said a CT1, CN?
CN1.
Why N1?
Because clinically only a single node palpable 2 into 2 centimeter, that is mobile, and it is on the unilateral side, sir.
Did you do a CT scan and CM?
Yes, sir.
CM. Did you do a CT scan of the CT scan abdomen pelvis? Did you do it?
Yes, sir.
What is the finding?
Sir, on CT abdomen, it is contrast enhanced CT of abdomen. On there is bilateral cortical cysts are there, and no retroperitoneal lymph nodes are seen. And on CT pelvis also there is no lymph nodes are seen, and on CT pelvis there is one external iliac lymph nodes are seen here, sir. Large external iliac lymph node is there, sir.
So it's a pelvic node, no?
Yes, sir. Pelvic node, sir.
Pelvic node, sir.
So if it's a pelvic node, will it change your T staging, N staging?
Yes, sir. Yes, sir. It will come out
Yes,
to
sir.
be N3, sir.
N3.
Yeah, but you said N1 just now.
So clinical palpable.
No. Clinical staging means you have taken all things that are available at your information. It means you have done a clinical examination, you have done a radio. If you have taken clinical examination, you have taken ultrasound, you have taken CT scans and everything. Based on everything only you come to a clinical staging. Clinical staging doesn't mean only clinical examination. It means clinical examination plus
plus radiological investigation.
all radiological investigations that are there at your disposal. So if you say that there is an external iliac node present, it is no longer an N1 disease. It may or may not be metastatic. That's a different issue.
Sir.
It may or may not be metastatic. That's different.
Yes.
So this is clinical staging. So it's TCT1, CN3,
3
and CM.
0. No metastasis is there.
You didn't tell me what is there on the X-ray chest.
Sir, X-ray chest was normal. No,
That
no
you have not
picture is not
mentioned.
there.
Yeah, you have not mentioned also. So you should mention. So distant metastasis. So staging is local, regional, and distant, isn't it?
Yes.
Should you do an image, Dr. Nitesh? It's 1 hour is over. I'm not sure whether we can continue, right?
Time is not a constraint. You can continue.
Okay, fine. Thank you.
From our side, there's no constraint of time. You can continue as much as you can.
Okay, fine. Again, just to complete the topic, do you want to stage the local disease by doing an MRI or an ultrasound or anything to stage the local disease on the penis?
Sir, we can do MRI, sir, to know if there is corpus cavernosa involvement is there or not. But we have to do it in the erect penis. We can give the papaverine injection and we can.
No, but why do you want to do it? The question is not we can do it or not. Of course, we can do it. But why do you want to do it? When do you want to do it? Do you want to do it routinely or do you want to do it rarely? I mean, these are the things that you should think about. No, karne ko to kar sakte hain. That's not a problem. But when should you do it? Why should you do it?
To see the presence of corporal invasion, basically. And,
how does it matter? I'll say that you are going to do a partial amputation anyway. So how does it matter whether corporal invasion is there or not there? That anyway you'll detect it on the post-op histopathology. So whether it's there or not there in the pre-op imaging, how does it matter? पता करके भी क्या कर लिया ना? You are going to do the partial amputation only. So you already know that MRI में it is invading. You've done a partial amputation. That also it shows invasion. So how has MRI helped you? Do you get my point?
Yes, sir.
Yes, sir. Yes, sir.
So when should you do local imaging of the penis in a penile cancer? Either
when
by
the findings of clinical examination are equivocal, we are not sure.
Or if it's
no.
high grade.
How does it matter? Grade is not going to again alter your management, no? See, if you're getting an investigation done, in other words, you have to act on that investigation. Some information you are getting based on which you are going to do something different. If before investigation you are doing partial amputation, after investigation also you are doing partial amputation, how is that investigation help you? Nothing. It helps you in two scenarios. One is if the tumor is very, very superficial and you are contemplating non-surgical options for penile cancer, right? If you are contemplating either brachytherapy or if you are contemplating external beam radiation, if you are contemplating non-surgical options, usually for non-surgical options, radiation and all, the outcomes for T2 and T3 are comparatively worse off with radiation as compared to T1 in view of local recurrence one. And secondly, if you give radiation and all that, for deep-seated tumors, it is difficult to detect a recurrence after radiation. So for these reasons, radiation is usually not preferred. Any other reason why radiation is not preferred over surgery? Mana?
Because recurrence is...
No.
Radiation will have complications, sir, much more.
Surgery also has complications. Every treatment has complications. So what complication are you talking about?
Sir, it will lead to corporal fibrosis, sir. So that may lead to sexual dysfunction sometimes. And
Correct.
it may cause urethral stenosis also, meatal stenosis, sorry.
Yeah, so the bigger reason is that you, by doing radiation, you can preserve the penis, but it will be a functionless penis because of fibrosis. Whereas in partial amputation, although you'll have a shorter stump of the penis, it will still be a functional penis because it doesn't cause fibrosis. Although with modern, if you tell that to a radiation oncologist, they'll get very angry because with modern techniques of radiation, there are multiple ways in which you can ameliorate all that. But anyway, coming back. So usually you do penile MRI when you are contemplating non-surgical options for treatment where accurate staging is needed. So whether you want to know, irrespective of whether you're giving radiation for T2, T3 or whatever, you want to know what is the accurate staging before you give the radiation. That is one scenario in which you do MRI. The other is when the tumor is quite large, if it is coming up to the base of the penis, if it is involving the adjacent organs, at that point in time, and a CT scan is very inadequate or insufficient for soft tissue delineation. So in those cases, you will probably do you will do an MRI to see the extent of local invasion when it's a T4 lesion. So those are the two scenarios where you commonly do an MRI of the penis to stage it. Okay, fine. So now you have a CT3, CT1 bar 2 with a CN3 node, CM0. What will you do next?
First of all, I'll do the partial penectomy. I'll treat the primary tumor.
So will you do everything as a stage procedure? Will you treat the penis, the groin as in two separate times? Will you treat it together? What? Kya karna?
Sir, I'll do stage procedure, sir.
Why?
Because if we are doing the partial penectomy and the lymph node dissection on the same stage, then there can be edema at the site and more of
edema at which site?
At the penile operative site, sir. Primary site.
Really?
Because of the inguinal
lymph node dissection also lead to more of seroma and more of lymphedema.
So because of inguinal lymph node dissection, there will be impaired lymphatic drainage. So there will be the penile swelling will be there, and that will lead to the difficulty in the healing of the penile wound, sir. So stage.
So you are not wrong if you say this, but this was a slightly older concept when patients had larger nodes, inguinal and all those things. Nowadays, most people who treat penile cancers, you are not wrong. I'm not saying you're wrong. You're right. You're not wrong if you say this answer. But you will be equally right also if you say that you want to do it simultaneously. The risk of having penile edema, penile infection, or from penis you are operating, groin site infection, there is really, people have done multiple studies over this staged versus simultaneous. There is really no difference in terms of outcomes, either infection, wound healing, complication. Everywhere, in simultaneous versus stage, the risk of infective complications appears to be exactly the same. But you are not wrong if you say that that's your institutional protocol and that's what you want to do. That's fine. Okay, so you've done a partial amputation. What is it? Do you have a biopsy for that? Yeah.
So moderately differentiated squamous cell carcinoma, invasion of corpus spongiosum and cavernosum seen, margin free of tumor, and right inguinal lymph node, two lymph nodes show metastasis.
No, you leave the inguinal. So you've done a part. So yes, you've done the partial amputation you have done. So after the partial amputation, you want to do it as a stage procedure.
Yes, sir.
So how long after the partial amputation do you want to do the groin?
Sir, after
3 to 4 weeks, sir, we can go for lymph node dissection, sir.
Okay, what will you do? What lymph node dissection you do? Suppose you get the final histopathology, that's fine. So what lymph node dissections will you do? On the right side, on the left side?
On right side, we'll go for, sir, radical lymph node dissection, sir.
No, don't say radical and non-radical. You tell me what stations of nodes will you remove?
Sir, I'll remove the inguinal nodes. I'll remove the ilial and pelvic nodes. And
on the right side?
On the right side, sir.
On the left side?
On the left, as as there is involvement of corpus spongiosum and cavernosum, it is T3 stage. Then I will do the superficial inguinal dissection on left side. And we'll do the frozen section. If it is positive, then we can go for deep inguinal lymph node dissection.
And iliac dissection.
Iliac.
So, I mean, you will do this in all cases. What is the recommendation? What do the books recommend?
Sir, if it is in high grade, like T3,
अभी
G2.
grade अभी आ गया आपके पास में, अभी if वाला सब
Yes, sir.
खत्म है अभी.
Yes, sir.
You have a
In-
moderately differentiated squamous cell carcinoma with a node that is positive on the right inguinal region.
Yes, sir.
Now, what will you do for the groin? And on CT scan, you should only one node in the inguinal region, one node in the pelvic region. One inguinal node, one pelvic node. So you will do will you mandatorily do pelvic for all patients?
Yes,
Suppose
sir.
that iliac
On-
node was not there.
On
Suppose
right,
Sir,
on
suppose
right
you
side.
iliac nodes are two or more than two iliac nodes are present, then we should go for pelvic lymphadenopathy, sir, as per EUA guidelines.
Two iliac nodes. No iliac nodes are present.
Inguinal, sir.
Correct. So what is the EUA guideline? Would you like to tell that again clearly?
Yeah, two or more than two inguinal lymph nodes are present, sir. Then we should go for pelvic
Present,
lymphadenopathy, sir.
not present. Positive. Positive, not present.
Positive, yeah, positive.
So how will you find out whether two or more nodes are there? Will you send everything for frozen section or how? You'll do two procedures. One, you'll do inguinal block dissection. You'll send it for histopathology. And suppose final histopathology tells you node is positive. Will you then go and do the iliac dissection as a third surgery? How?
In this stage, high grade, we will go right side. We'll go for ilioinguinal dissection, sir. We'll do pelvic node dissection also, sir.
But suppose pelvic nodes are not there. That's what I'm asking you. There are radiologically pelvic nodes are not there. What will you do then?
Then also, if FNAC is positive for malignant cell, we'll go for right side. We'll go for pelvic lymph node dissection also.
I also do the same, but I'm asking you why you want to do it.
Because
recommendations say that you
because if inguinal lymph nodes are positive, then it can go to pelvic lymph node.
No, Manav, understand my question.
Yes.
The NCCN recommendation and the UA recommendation states that you should do a pelvic node, pelvic lymphadenectomy only under two circumstances. Either there are two or more positive inguinal nodes, or there is a single node with extracapsular invasion. Understand?
Yes.
So this you will not get it on frozen section, because frozen section can tell you only if node is positive or negative. Frozen sections cannot talk to you about extracapsular invasion. So for that you have to you have to do an inguinal lymphadenectomy and you have to send it for histopathology. The histopathology may only you will come to know whether extracapsular invasion is there or not and number of nodes are there or not. Based on that only you are supposed to do the iliac dissection, yes or no. Do you understand my question?
Yes, sir.
Yes, sir.
So I am saying, what is your practice? You are saying that you will do iliac lymphadenectomy irrespective of number of nodes and capsular invasion. Correct?
Sir, if as a disease is high grade, sir.
No.
No.
It's not high grade. It's only moderately differentiated carcinoma. It's grade 2. It's not grade. It's not grade 3.
But it is T3, sir. Invasion of cavernosum and spongiosum is seen, sir.
See, that is over. That is over. The T stage and the grade predict risk of nodal metastasis. It does not predict the risk of pelvic node or inguinal node metastasis. T3 or grade of tumor predicts node is a risk factor for nodal metastasis. Metastasis has come. Now I'm asking you about surgery for pelvis and inguinal. When will you do pelvic lymphadenectomy? When will you do inguinal lymphadenectomy? Whether you do both or not, and what is the justification for doing it?
Yes,
sir. As you told, sir, that two or more than lymph nodes or extranodal invasion with one lymph node, then only we can go for pelvic lymphadenectomy, sir. Otherwise, there is no need of pelvic lymph node dissection, sir.
So you will do only an inguinal lymphadenectomy?
Yes, sir.
Amit, you will do inguinal and iliac both?
Sir, no iliac lymph node dissection, sir.
Mana, what will you do?
Sir, according to EAU, and they have said that we can do ilioinguinal dissection, sir.
No, they have not said you can do ilioinguinal. They have said you should do only inguinal. If only more than 2 or pelvic only, you should do iliac. They have not said you can do ilioinguinal. So the reason is you are correct. You are not wrong if you say that I will do, if there is a inguinal node positive, I will do inguinal and iliac together at the same time. You are not wrong. In institutional in India, most people, including myself, we do ilioinguinal and we don't wait for the total number of nodes or the extracapsular invasion on the histopathology, because that is purely because of logistics. When a patient comes, you cannot, in India, it is very difficult in our scenario, the patient population that we are in, to say that you will only do the inguinal lymphadenectomy as one surgery. So you've already done 2 surgeries. One, you've done a partial amputation. Then 4 weeks later, you call him back and you say, I'm going to do inguinal lymphadenectomy. Then you call him back and say, as third surgery, I'm going to do a pelvic lymph node dissection. So that is extremely, in terms of compliance, in terms of getting the surgery done, in terms of logistics, in terms of, economic and money and all those things, it is very difficult to organize all these things. So purely for logistic purposes, because iliac lymphadenectomy, the morbidity, it's not a very morbid, it's not a very morbid procedure. The morbidity that happens is no more than what you would do for an inguinal lymphadenectomy. So for ease of completion of treatment, is why we do both an inguinal and iliac at the same time. That's the answer that you have to give in the exam. Are we clear here?
Yes.
Yes, sir.
But if Amit wants to say that I want to do an inguinal and based on histopathology, I will do an iliac as a third stage procedure, you are not wrong. You are correct by the textbook. Manav, if you give this answer, because that is what we do in practice, you will be right. Both answers are right. You just have to play it this way and that way. What are the limits of iliac lymphadenectomy?
Sir, iliac lymph node, laterally there is genitofemoral nerve. On medially there is internal iliac artery. Superiorly,
No.
common bifurcation of the common iliac.
What is medially? Laterally, genitofemoral nerve. Medially?
Internal iliac.
No.
External iliac.
No, that is laterally genitofemoral nerve. Medially, the base of the bladder and the ureter. Proximally
is the there is a bifurcation of the common iliac, and below is the Cooper's ligament.
Distally.
Distally
Cooper's ligament is difficult to feel because it's beneath the fascia. What is the surrogate marker for that? Is there some deep vein which goes there deep?
Femoral.
Not femoral, deep inferior something vein is there. Deep inferior epigastric vein goes down like that. Okay, doesn't matter. Fine. So what is, okay, I'm not going into the details of surgery, whether it is template or non-template, what is modified, this and that. But just in a small view, you said superficial inguinal block dissection for the left side. So why don't you do a deep, what is superficial inguinal block dissection? That alone you tell me.
Superficial is mainly we are going above the fascia. We are not going below the fascial lata. We are going above the fascial lata, and in this we are taking the boundaries as medially there is a ductal longus. Laterally there is
ductal longus is कौन सा medial border, lateral border?
Lateral border of a ductal longus, medial border of sartorius, and above
lateral
there is
border of bilateral longus. Are you sure? Okay. So anyway, so what is the philosophy behind doing a superficial inguinal block dissection and not a total inguinal block dissection in penile cancer?
Sir, because the spread of the CA penis lymphatic first go to superficial, then it will go to the deep inguinal lymph nodes. Sir.
Yes.
There will be no. There is skip lesions are rare in.
Rare. There are no skip lesions in penile cancer. It will never skip the inguinal before going into the superficial before going into the deep and then into the into the iliac nodes.
Yes, sir.
Hello. Yeah.
Yes,
sir.
So again, now what is the final histopathology based on this? The final staging.
Sir, right inguinal lymph nodes, two lymph nodes show metastasis size 1.5 and 2 centimeter. No extra capsular invasion seen. Pelvic nodes negative for metastasis.
Stage क्या हुआ?
So stage is there is two lymph nodes, and there is no. It is N1, sir.
N1, M0, T1.
Okay, so if you have to say staging, one of the important things why we want to do staging is because we want to know the prognosis. So if you say that single node or one or two inguinal nodes, so what do you think is going to be the prognosis for this patient? 5-year overall survival.
Sir, 5-year overall survivor. If we are surgically treated, it will be
Now you-
60%, sir. 60%, sir.
Yes, sir. 40 to 60%, sir, if you are treating the lymph node.
In
No, no.
N1.
See, the prognosis will differ based on there are no inguinal metastasis. There is a single inguinal metastasis. There is more than one inguinal node metastasis or bilateral metastasis or pelvic node metastasis. Do you understand?
Yes, sir.
No metastasis,
Yes, sir.
single positive node, more than one positive node or bilateral positive nodes and pelvic nodes. So can you tell me the prognosis? So this is more than two nodes
Yes, sir.
positive. So what
Yes,
is the prognosis for each of these group of patients?
Yes, sir. If there is no nodes are positive, then it will be 80%, 70 to 80%. If
No
single
nodes, no inguinal node metastasis is 70%. No, no, no,
Sem-
no. No.
70 to 80%.
For no inguinal node metastasis, the world review of literature will be about 85 to 90%. 80 to 90% will be the, in fact, more than that, 80 to 85 to 95% will be for no inguinal nodes. For a single inguinal node is about 70 to 80, 70 to 80%. 70 to 80% is solitary inguinal node. 40 to 60%, or rather they say 30 to 60% is for bilateral or multiple node, more than one inguinal node metastasis. For pelvic node metastasis,
is a 5 to 10%, sir.
yeah, usually is what they say is 5 to 10, but in conventional practice, iliac node metastasis, the survival is you should not start from 5 to 10, you should say 0 to 10. For most patients with the iliac node metastasis, the survival is 0%. Especially most of the published Indian literature, the pelvic node positivity is 0%, 5-year survival. Right? Adjuvant therapy.
So, in this,
What would be the indications for adjuvant therapy? What adjuvant therapy will you have? Adjuvant chemotherapy, adjuvant radiation? What regimen?
So indication of adjuvant therapy is when bilateral inguinal lymph node positive, pelvic nodes positive, extranodular extension is there. Then we will give adjuvant. Adjuvant we can give in the form of
number of nodes, number of inguinal nodes.
More than two. Than two.
No.
More than 3, sir.
Yeah, more than 3. So 4 or more inguinal nodes, bilateral nodes, any extracapsular invasion or
more than 4 centimeter. More than 4 centimeter inguinal node.
Or pelvic node positive.
Yes.
So these are the, yeah, tell me something you're saying. These are the indications for adjuvant therapy. What adjuvant therapy will you give?
Sir, we can give paclitaxel, ifosfamide, and
no. That is for much later. Will you give adjuvant chemotherapy or adjuvant radiation?
So chemotherapy.
Chemotherapy, sir.
Chemotherapy, sir.
What chemo? What is the best chemotherapy in today's day and age as adjuvant therapy in penile cancer?
Cisplatin based chemotherapy, sir.
Now, base का क्या मतलब है? What do you mean by base?
Cisplatin, 5-fluorouracil, or ifosfamide, sir.
Does the regime have a name?
The TIP regime is there, sir.
TIP regime.
Paclitaxel, ifosfamide, and cisplatin, sir.
Yeah, TIP regime is there.
Yes, sir.
How many cycles of chemo do we give usually?
So 3 or 4 cycles, sir.
There is no 3 or 4 or 5 or 6. What is the conventional thing? How many do you give? 4 cycles. What is the evidence for? Is there any evidence for adjuvant chemotherapy? That more than 4 centimeter node that you said, no, that is not for adjuvant chemotherapy. That is for neoadjuvant chemotherapy. Yeah, for adjuvant chemotherapy, there is no more than 4 centimeters. The size of the node is not a determining factor for adjuvant chemotherapy. Only number, bilaterality, extranodal involvement, and pelvic nodes.
Yes, sir.
Yeah. So, what is the evidence? Do you have any evidence for adjuvant chemotherapy? This is not a trick question, man.
Yes, sir. Evidence is there. That's why I.
No, there is very little data to give adjuvant chemotherapy in penile cancer. Our own institute data has just been accepted for publication. But then again, the data for adjuvant chemotherapy is not as strong or not as robust as is the data for neoadjuvant chemotherapy. So most of the adjuvant chemotherapy that we are giving is based only on very little actual adjuvant chemotherapy data. Most of it is extrapolated from neoadjuvant chemotherapy because in these high risk patients which we've already defined, neoadjuvant chemotherapy seems to work. So it's been extrapolated here also that more than 4 nodes and all these patients, they have a high risk of both local regional as well as systemic failure. So that's why adjuvant chemotherapy might work. But if you look in terms of absolute numbers, the data is actually very sparse. There is very little data. Right. What about adjuvant radiation?
Sir, we can.
The radiation is only for palliative treatment, sir. For nodal, there is no recommendation.
Is it?
As per EAV guidelines, no.
What about NCCN guidelines?
It can give CT RT. We can.
Yeah, again, why don't we give adjuvant radiation? Although there is some data, NCCN data is there, and all those things are there. EUA doesn't recommend, but NCCN recommends. But most people don't give adjuvant radiation. Why?
Same complications are a little bit high.
Not a little bit high. They are quite high because inguinal lymphadenectomy itself carries quite a lot of morbidity. And if you're going to give adjuvant radiation on top of that, the lymphedema rates and are extraordinarily high. So that's why most people would hesitate to give adjuvant radiation on top of lymphadenectomy. Although, what would be an indication to give? When will you think of giving?
Patient is fit, not fit
No, not fit. It's only based on pathology. When you have a lot of adverse prognostic factors, especially if you have extensive lymphovascular emboli seen everywhere, sometimes there will be dermal and subdermal infiltration of tumor. If you cut open the specimen, there is extensive lymphatic tumor emboli everywhere. That would be one scenario where a lot of people would consider giving radiation, although the data again for adjuvant radiation is not very strong. So that comes to the last portion of our review. How will you follow up these patients?
Sir, we'll follow up this patient as this is grade 2 tumor. Then we can 3 monthly for first 2 years, and then 6 monthly for next till 5 years, and then one annually we can follow.
How will you follow them? Will you do only a clinical exam? Will you do imaging? Will you do a radiological exam? What will you do? You'll do only clinical exam.
Sir, we'll do physical clinical examination, sir.
And we have to tell patient also self-examination is also important part of follow-up.
Or if needed, if nodes are enlarged, we can on the left side we can do by FNAC also, sir.
Yeah. So a good clinical examination. Will you do an ultrasound?
Yes, sir. We can.
When will you do? So clinical examination, you said 6 monthly for first 2 years.
3 monthly for first 2 years, sir.
3 monthly for first 2 years, 6 monthly from year 3 to 5, and then annually. So that schedule is correct. But what will you do in that schedule? Only clinical exam, only radiological exam every yearly. What will you do?
Sir, we'll do clinical examination, sir.
Only all throughout. So, kabhi CT scan, ultrasound, nothing. You'll never get anything done.
Sir, if there is a local recurrence, then we'll go for sir imaging study, sir.
How will you? That's what. How will you detect recurrence? By the time you palpate a recurrence, it will be too large, no?
We'll go for CT scan, sir. CT.
How frequently? So what you said now is perfect as per the NCCN. because NCCN only recommends a clinical exam for an N0 and an N1 node, which this is. But in clinical practice, most people at the end of 1 year or at the end of 2 years would until at least 5 years would get an annual CT scan of the abdomen and pelvis done, or at least an ultrasound of the groin to detect any nodal recurrence or anything is there. That again is dependent on institutional protocol. So you can say whatever answer. What you told me now is exactly correct as per the NCCN. There is no doubt in NCCN N0 and N1. That is the follow-up. But the follow-up may also change for doing some imaging studies based on your institutional protocol, whether you want to add some imaging or not, whether it's CT scan or an ultrasound or something like that. You are not wrong. I think that concludes this case. I think Dr. Nitesh, if you have any expert comments, if you want to summarize it. Yeah. I think it's a case well presented, Manav and Amit. But just only a few impressions insofar as the management is concerned. I think both of you did a good job. Just that a few things you need to learn better. But I think where both of you were not very good, or where you were a little bit, at sea, is in the initial portions in the pathology and all those things. So that is something HPV, pathology. Uh, you stage the disease before you had the diagnosis. So those kind of basic errors you should not make. Investigations and diagnosis, I think you are all right. The pathology needs a lot more, I think, input from your side. Don't just think that it's some random thing. It has got clinical and implications to it.
Thank you, sir.
Thank you, sir.
Dr. Nitesh, any expert comments?
Thank you, Dr. Anand. It was an extensive and quite beautifully taken class. Wonderful. Thank you for your inputs, and thank you, Manav and Dr. Amir, for coming forward and presenting the case. Thanks
Thank
a
you.
lot.
Thank you, sir.
Thank you. We can now
We'll
leave the
need
session.
few more of your classes.
Sure, sir. I'm available anytime, sir.
Sure. Thank you. Thanks a lot.
Thank you, sir.
Thank
Thank
you.
you, sir.
We'll sign off.
Thank you.